Buen dia. I'm very happy to be in this absolutely magnificent building and place and foundation. I've looked from afar for a long time, wishing I could come here, let alone get the opportunity to talk. So thank you very much. This is a very great opportunity. So I'm going to talk about the vision. I say vision, not a dream, because a dream is looking back. A vision is looking forward, and you can only accomplish what you envision. That retinoblastoma can be a zero-death cancer worldwide. All the logos that are shown there are all have some relationship to my work, but I'm only paid to see by patients, so I have no conflicts of interest with any of them, but I owe them all a great deal for the efforts and funding that has gone into all the things I will talk about. Where are the children with retinoblastoma? In the world, there are, this is based on 2016 data, so there's a few more now. 8,000 per year is the number we generally use, and we calculate the number per country based on the infant mortality rate and the birth rate. And India has the most because they have the highest birth rate, but not the highest population yet. And China is second with more than 1,000 per year. You can see that Canada has no business working in retinoblastoma. We have 23 new patients a year, but we've mined those patients for the gold that they've offered for cancer in general in many, many ways. How many children die of retinoblastoma? You can see that very appropriately for this amazing institute is unknown. However, if you compare the mortality in North America to Kenya, it's 3% or less in North America and 70% in Kenya, as of 2012 paper by Naomori. Of course, that has changed a little because of work in Kenya to pull together a national retinoblastoma strategy, which has made a difference. But we don't have data to support any of these. We have no global figures for mortality because we don't know what happens to every single child when they're diagnosed. We don't even know how many, except for our estimates, and we certainly don't know what happens to each child. Why do they die? One of the big reasons that's very obvious is late diagnosis. They all show leukocoria, and the parents notice this long before they're brought to attention. Once the parents bring them to attention, most of the medical systems in the world shove them away and say, oh, it's nothing, they'll outgrow it, and that adds to more and more late diagnosis. Bad biology, sure, there could be worse retinoblastomas that have changes that make them kill the child. But basically, if the tumor is inside the eye, when that is removed, the lumpectomy of the whole eye, that child lives. If it's outside the eye, the child will die, pretty much. Third, medical errors, and there's a lot of medical errors, and I will confess that at the Hospital for Sick Children, where we've counted all the deaths in Canada over the last years, there are three. Two of the three are pathology failure, so that the adverse risk feature in the eye was not noticed. So pathology failure is a big error, but there's lots of other medical errors that kill children, and I'll come back to some of that. And that relates to the eye being valued by the parents more than life. And that isn't the way they start out. In the old days when we took out all the eyes with retinoblastoma, lots of bilaterally enucleated people grew up and led fantastic lives. I know the best musician in Kenya has no eyes because his life was saved by a brilliant surgeon. But when we offer to save eyes, the parents grab hold of that and it becomes a false hope because there's no possibility to save those eyes, but the eye goes on to kill the child. And that's a worldwide problem today, and it's the fault of ophthalmology. And then there's all sorts of unknown things, perhaps, but we only know, I couldn't think of any other things we really know why they die. How to get to zero deaths? We want to go from this 70% death rate that's estimated to zero. Late diagnosis, there's very exciting things happening in a project led by Didi, now in Israel, on looking at the presenting features and the presenting year of life of every child with retinoblastoma. And they're very vigorously recruiting centers all over the world. It's going to be a very global program and really very excellent, beginning to say why late diagnosis, leading to then solutions for awareness. One of the obvious things that's bringing retinoblastoma to attention is the internet, because parents everywhere on their cell phone take a picture, say, why is there a white look in my kid's eye? Go to the internet and say, my kid has retinoblastoma, and then face the challenge of the medical system blockading them from that stupid diagnosis, which couldn't possibly be true, which is true. Bad biology. The genome project on cancer have consumed a lot of the research that might have gone to global health, but so far in retinoblastoma, there's no new drivers have arrived from drivers of cancer. I mean, driver genes that drive the cancer, not passenger genes, which are just emerging. And passenger mutations will emerge because loss of the retinoblastoma gene, the fundamental thing it does is lead to genomic instability. So then the rest of the genome hasn't got all the right checkpoints anymore, and that's a cascading effect causing more and more proliferation. And we have a paper submitted, but not yet accepted, showing the clonal evolution is a very prominent feature of the tumors that have lost the RB1 gene, whereas it's quite absent in the tumors that are driven by the McN oncogene, which have very few genomic changes, other than the presence of high-level McN oncogene. And so bad biology, you would hope, would lead to targets that you could then build a magnificent therapy that would kill tumor cells and save eyes and save children's lives. But there's a lot of issues to get past before we achieve that. And then the medical errors that I referred to, and the over-treatment, which I would define as an error when the eye obviously should be removed and instead goes on and on with many treatments to save it. And the false hope. Where is the care for retinoblastoma? Helen Damaris, who was a molecular student in her molecular PhD in my lab, she defined retinoma molecularly, which has recently become, at the last FARVO meeting, a very exciting topic by definition by David Kobrinick's group of all the steps towards retinoma and on to retinoblastoma at a new level. Helen then became most interested in her passion is global health and education, and she's building her own career in those areas with very dramatic students all over the world, moving back and forth around the world and working together and working very strongly on patient advocate stories. And one of her projects is the MAP, One World Retinoblastoma. If you put in onerbw.org, you will go straight into the map like this, and then it will lead you to this appearance. All the green little balloons are retinoblastoma sites, 178 treatment sites in the world mapped out. And then you can go and point to anyone or go to any country and ask, where should I take my child? The parents go from the white pupil to the map, and then they know where to go directly in their country, and they know who to contact to get care, so they can sort of bypass that obstructing health system that's preventing them getting to the care they need. The problem with this is that it needs to be updated, and it needs to be manually updated. So her students, once I was actually in China, when her student contacted me and we did a big interview on how many patients and the status of the Hospital for Sick Children to update the map. But it was very interesting dynamic around the world. So it's always a little bit out of date. That's why this is September 17th, 2017, as opposed to today. So the project I really would like to present to you, so that we move from unknown to know, but I didn't say no because we haven't finished this yet. We haven't even actually started it yet. We've just done a huge amount of work for more than 15 years to get ready to start maybe in 2018. If you go to that URL, and I can give you a card to remind you what it is, and you put in the obvious passwords, username demo user, password demo 1234, you will get right into the demo website. So I'll show you what you'll find. It's called now Depict Health, although the website doesn't call it that because this is a new name that our advisors have moved us forward to Depict Health. This is a summary of the whole child. And you can see, does this work? Yes. So this eye was lost because the vision was 600. The other eye has been saved, and we're way out here past June. In fact, just 2 weeks ago, we examined this child. These are, by the way, real children put into the demo with their permission. Their name is changed, their sex is changed, their dates of birth are changed, but the rest of it's real. Otherwise, we couldn't make up a demo retinoblastoma child. And the children have picked their own names, if they're old enough to do so. And you'll see it shows immediately the new classification, the 8th edition TNM classification. And the right eye is a clinical T1B. The left eye is still clinical T2A. And it summarizes the whole staging up here. T2A, the brackets are the less involved eyes, so the overall cancer staging would be the T2A, driven by the worst eye. And each of the vertical lines across the bottom are visits. The red is the most important one to start with, which is the staging EUA. The rest are all EUAs, but other tests, other clinic visits, which haven't been entered in this demo, would show up as green, etc. The lines that go across both eyes are systemic chemotherapy or genetic testing, or some other things like death would produce a black line across here, because that goes to the whole patient, whereas the features that are the icons within the eye space are focal therapy for the eye, like intraarterial chemotherapy, etc. The staging EUA is what I'm illustrating here. These fields, the visit details, exam, imaging, etc., are just data fields, not so interesting to show you. But what's fascinating is this drawing tool, which works very well. It's a vector diagram, so if you pick up the drawing tool over here, like tumor, and you get a drawing tool which lets you draw the tumors as you see it and map it out in the whole eye. This is not a photograph, it's drawn from the photographs, but it's much more useful and accurate to see the whole thing in a symbolic way. Of course, we follow the same color scheme that's been used ever since we've been doing drawings of retinoblastoma on paper for the last 50 years. It's exactly the same template as that, with an optic nerve and an X, which you can't see here because the tumors are on top of it, for the center of vision. And you can see that I can't demo it because it's not live, but I'd love to demo it to anybody who wants to see it live. We can go on to it in any coffee shop in the world with an internet, and you can draw the retinal detachment, and it would record the vector, the quadrants that are involved automatically. And you don't need to name which eye you're drawing on because it knows which eye you're drawing on. So all that data is being collected in the background, and the computer's doing all the work, and all you need to do is try to be a good artist. I have a summer student this year who's a brilliant artist, and she's developing the manual for teaching people how to do this as their summer project, to do the drawings very nicely. But the content's more important than how beautiful it looks. And then we can go over to jump to images, and we upload critical images. So you can see this is this child's left eye shown here with the tumor, and the yellow shows where the center of vision is, so he does not expect to recover vision in this eye. But the other eye, the right eye, has the optic nerve clearly visible, and the tumor up to the side of it. And with the treatment, attempting to save the left eye and right eye, we failed and ended up removing the left eye because you can see here all the little yellow spots here. We've been treating and treating and treating with laser, with more chemo, with intraarterial chemo, and failing. And then what really drove it was the tumor on top of the nerve, and we could see that by OCT. And this is the tumor that had been growing, very difficult to see, and you see the little gray patch, that's right there, is represented by this. So intraretinal tumor, it was growing flat out and you could hardly find it. It wasn't a big, white, obvious thing. So we said, this is silly. This is a 2600 eye. It's time to take out this eye and save the child any more risk and get on with life. So this is what Depict Health does. It brings the whole healthcare team, the circle of care around each patient together. And all these different people illustrated there are all working in a retinoblastoma center of excellence, working towards care for each individual patient. All the data that I'm showing you, the timeline, everything, is viewed by everyone in the circle of care. Those in the institution would be authorized to enter data, including the oncology, the radiology, the genetics. Everybody will be accessing it and entering their contribution to the story for that child online. Not in the institution, but online. And the family and anyone else they wish to join, like the parents, grandparents, legal guardians, their pediatricians, doctors, whoever they wish, they can authorize to actually view. So they'll be sitting in the waiting room with their iPad watching as we upload and do the drawings in the OR. And it's very straightforward at that point. So the circle of care becomes a team working for the survival of the child and as many eyes and vision as possible, but not at the risk of life. And the Depict Health whole model, by doing this, by going through the checklist, going through the database to enter things, it becomes a checklist. It actually guides what you should be doing next in a very subliminal way. It's not telling you what to do, but it actually achieves that, and we've experienced that at Sick Kids. So it's structured with a whole governance plan built, modeled, and with help from the group in Montreal, led by Bertha Knopfers, Canada's top ethicist, and in genomics, to the International Genomic Cancer Project. And so we have a steering committee, operations committee, workings groups. The sites would be centers of excellence that join in, and they communicate. We're not hosting any data. We're not custodians of any clinical data. We're enhancing communication across the circle of care. And the patients, of course, participate. And the people in the sites, leading the sites and working in care of the patients, will all take turns being on the steering committee's operation and doing all the work. So it becomes like the College of American Pathology conducts inspections of each lab, and everyone, including me, would inspect another molecular lab, and that get inspected in turn by somebody else from another part of the world. That will be a model we will work on to keep us all to the right standard. The data out of here will go to research. Then that can be mined. There's a whole process for what research can be done and how to be done, how to be acquiring the data. Then that real world evidence will ultimately feed back to the next child and the next patient. We also have a tissue bank in Sick Kids, which has every single tumor I've ever taken out of an eye since the mid-70s. And some from when I was in New York. And that tissue bank is a real tissue bank, but we propose a virtual tissue bank where every center can have their own specimens, but the data would all be in one place. And here we wouldn't build this data, it wouldn't be in this database. There's a beautiful database from Germany for tissue banking, and that's where all the data would be, but it would be virtual globally. So you may be wondering, how are you going to deal with privacy? And how are you going to put this in Europe, which has the most rigid, stringent, brand new, and changing every day, so you have to keep up with the new laws. So we really are going on the cloud now. We've talked about it, but we've not actually done that before. But now we really will be on the cloud. And Europe will have the patient data in Depict Health of Europe patients will be in Europe, in China, in USA. The controls will be where we don't have any data. It will still be in one central place for logging in when it's not health data. And this is very exciting how this is working. So that, for example, the patient data, the site data, and the tissues, which are containing private health information, will all be local in the region that they are living in. So we had great help from graphic people who built this for us. This is showing the whole world of retinoblastoma, all seeing the whole world together and working strongly to lead, I think, in cancer and in health by putting all the critical components for a rare disease in one space to mine and turn that into real-world evidence to change the future and achieve 0 deaths in retinoblastoma. Thank you.